Shut up! Welcome back to Conversations with Carol and Cheryl. Today we continue our mini-series on elder care. This episode focuses on medical considerations as you care for an elderly loved one. We begin with attorney Andrew describing Lewy Body Dementia symptoms that his mom presented with. For more information on Lewy Body Dementia, click the link in our show description. Andrew.
My mother died from Lewy Body Dementia. It's spelled Lewy. Lewy Body Dementia. It's named after, I believe, a German doctor who was doing an autopsy on someone about 100 years ago, and he found these protein deposits in their brain under microscope, and that's why they're called Lewy Body deposits. The symptoms present like Parkinson's on steroids, with the shaking, drooling, problems sleeping, confusion about whether a dream actually happened, hallucinating during the day. The walking becomes more like a shuffle, hunched over posture.
Her gait was more shuffled. Her posture was, yes, definitely hunched over. I did not see an intention tremor initially. She had somewhat of a mask-like facies, which is the medical term for it, but it's a loss of her spontaneous smile, even though I thought she was sad and her face was less expressive. Her voice was quieter. And I think that she likely had this going on for a while, but she kind of covered it up. And I think the stress of losing my dad, stress makes everything worse. I think that hastened her progression, along with just regular aging mixed into everything. And then different parts of your brain deteriorate at different rates when you age anyway. Even though this was going on, she was misdiagnosed. I had to be an advocate. When I came to see her in the hospital, they initially were working her up for a stroke. So she was admitted, and I kind of looked at her and I texted my siblings and I said, I think mom has Parkinson's. And the next day when the doctors were doing their rounds, I was there and I said, I think my mother has Parkinson's. And they looked at her and they said, you know, you're right. And then I said, I think she needs a neurology consult. And there was just one neurologist in the whole area of Cape Cod, and he happened to be doing his rounds in the hallway, and they pulled him in. I said, but she's having hallucinations. And he told me that was Lewy Body Dementia. He made the diagnosis in 30 seconds. Because I'm a doctor, I do have some power with that, but I'm also a kid. You know, I'm a child of my mother, and I didn't want her to have something terrible. But taking a step back, I do have some power to say this is what I think my mother has. And I think they had to take me seriously.
When did you first notice signs?
Mid to late 2016.
So it went fast.
And this diagnosis that Lynn is talking about probably was early summer 2017. We saw symptoms. We took her to her family care physician in 2016. He had her count backwards from 100, like by 7, like 193, 86 or whatever. And again, my mother's dementia, it wasn't that kind of dementia. She could do that. She could tell you what she had for breakfast that morning. So he's like, oh, she's just getting old. Oh, she has a shuffled walk. She's just getting old. She's hunched over. That's what old people do. As part of being an advocate for your elderly loved one is getting them into the specialists that deal with geriatric care. If someone is presenting symptoms of Parkinson's or symptoms that are neurological, getting them into a neurologist that specializes in, say, a movement disorder or something.
Now, you were saying that if you had diagnosed it earlier.
Now it's 100% fatal. But they can tell the family what the next X years are going to be like so you can start to plan. And her symptoms were deteriorating and we're just acting like she was aging. I mean, as far as I was concerned, she was very anxious and grieving over my father. And I was trying to kick her in the rear end to be like, hey, life goes on. You need to sell your house and you need to downsize and stop being so stubborn. I was just feel horrible about that element of it, but I did not see my mother having dementia. I associate dementia with Alzheimer's.
You were being logical. Okay, these are the next steps. This is the best thing for you, Mom. That's where you were coming from.
That's what I was coming from. And again, there's no instruction manual. I had no idea what Lewy body dementia was. I had never heard of it before until she got the diagnosis. And then I see that 1 million people have it. It's a fatal disease. I'm like, how come this isn't common knowledge?
So, Lynn, what would you do different?
I think it was very frustrating that my mother didn't want to sell her house or move. I think that's a common thing with elderly people. I think their dream and fantasy really would be they stay in their house, all their kids are over 24/7, and they have family dinners every night. And that's fantasy. And I think just realizing that more with my mother and not disagreeing with her so much about that would be great. I would definitely try to move her closer to more specialists. I mean, she was on Cape Cod, but once you go over that bridge over the Cape Cod Canal, the medical care and access to care and the number of specialists decreases logarithmically. So you have to maybe look at, okay, this is what our resources are. This is what we need to take care of you, Mom. We need to move you. If you had a certain kind of cancer, we would move you up towards the specialist. Just because this is a little bit different than that, it still needs as intensive care. And you still need your specialist and maybe talk to her that way. I think we did the best job we could.
Sounds like it.
I think we did. Looking back and saying, oh, should I have figured this out sooner? No, I'm not her doctor. I'm her child.
It sounds like you're at peace. Even though it was a hard process, you feel good about involvement in it?
I think so. I work in the pediatric emergency department, but I get to see what my colleagues go through with their adult patient, and this is a very common thing.
I wanted to talk quickly about Medicare. Any U.S. citizen, if you're 65 or older, you get covered by this insurance called Medicare. As it applies to aging parents, I think it's important for everyone to understand what it covers and what it doesn't cover. We had some medical billing issues with our mother because of Medicare's limitations. And the first thing is, if somebody who's covered by Medicare is admitted to the hospital for less than 3 nights, you could well find yourself paying a really large bill. Lynn, I think that's the rule. 3 or more midnights, then Medicare picks up the hospital tab.
3 or more midnights. And you have to ask if they are being admitted in an observation status or not.
And again, I'm sure many of you listeners at home, you're driving your kids to soccer practice, you have no medical training at all, and you don't necessarily have the wherewithal to call up the hospital and say, my mother or father was admitted to the hospital. I'd like to know if this is an observational status or not. And you can also advocate for getting them admitted for 3 midnights. Otherwise, you might find yourself with a $6,000 to $8,000 medical bill.
I don't understand the observation versus treatment.
Okay, so there is different ways to be hospitalized. You can be admitted, full-on admitted, or you can be full-on admitted to inpatient status, or you can be admitted to observation status. So observation is providers want to make sure that that person doesn't have a certain thing, and they are mostly observing them to see if there's any progression of their illness and watching them get better. And it's typically less than 24 hours. And the admitted status for Medicare should be admitted to inpatient for observation and treatment and testing, imaging for that encompasses 3 midnight.
So the tie-in is if it's observation, treatment, Medicare will pay for it if it's 3 midnights. If it's not, it's going to be out of pocket.
Right. The doctor has to place the order to admit them to inpatient.
So what Medicare will cover is if your loved one has 3 midnights in a hospital and they need maybe more long-term care after they've been admitted, Medicare will cover a stay in a rehabilitation facility as they recover, but that's limited. And our mother had 3-day admissions in the hospital, followed up by rehabilitation facilities. But Medicare, this is the insurance that covers everybody who's over 65 years old, will not cover long-term care. If you need to be in a facility, assisted living, memory care, that intense nursing home care, if you need that for weeks or months or years, you are not covered under Medicare. And the cost of that starts at about $5,000 and goes up to $15,000 a month. So that brings the next topic that I did want to cover is Medicaid. Medicaid is the insurance program for the lack of a better word, poor people. If you're really, really poor in this country and you're a child, you're covered by Medicaid. If you're really, really poor in this country and you're a parent taking care of a very young child, you are covered under Medicaid. If you're severely disabled, you see parents taking care of a severely disabled child, with lots of expensive equipment and so forth, the chances are Medicaid, that program, is helping them out. As it applies here, many elderly people who have run out of money, but they need nursing home care or some sort of assisted living, it is paid for by Medicaid. Here's the catch. You must have all of your assets depleted to be covered by Medicaid. There are exceptions. Your personal residence, you're not forced to sell your personal residence, particularly if you have a living spouse who's living in it. But after you die, the state will come after your assets, whatever assets you have left over, to recoup the cost of what the state had to pay for your nursing home care. Nursing homes that accept Medicaid patients are limited. You may have a facility that has minimum wage employees. You may have a facility that won't care for your loved one the way they deserve to be cared for unless family members are there constantly monitoring it. I say this knowing that there are some people out there who deliberately impoverish themselves to qualify for nursing home care through Medicaid. They might be, say, somebody who's in their 60s, they own a house, they have stocks, and they've got assets, and they give all their assets to their kids. And then 10 years later, they need a nursing home. Well, on paper, they're poor because all their assets are gone, and they might qualify, but be careful what you wish for. You might not get a great facility. And the other chance you take is most Medicaid programs are run by each state. They can claw back 5 years. So they can look back 5 years. And if you've given away your house 3 years ago to your kids in a trust or something, the state can claw that back and just say, no, we're taking that house to pay for your nursing home care. Best thing you can do is either buy long-term care insurance or have assets set aside to pay for the best possible long-term care you can get. As it applied to our mother, we were able to sell her house in 2017 and get her into a really, really good private facility. We did not spare any expense. She had home nursing coming in even when she was in the facility. She had a beautiful facility with meals. It was wonderfully staffed and so forth. Everyone sit and pause as you listen to this. Her care was between $7,000 and $25,000 a month.
Basically, the sale of her house, the beloved house, paid for that. And I personally think that that's what my dad would have wanted. Homes are temporary things. That's how you have to look at it. And those skilled nursing facilities, they vary, and a lot of them are not very nice. If you can plan for things, long-term health insurance, it's much more affordable to obtain it when you are younger. So I know nobody wants to think about that. You can look at the scales. You can just go online and look at the scales. When I purchased it, I think I was 51 or 52 as a female, much cheaper yearly than if I had waited 5 years.
There are geriatric consulting companies that can help families, and we hired one. And they're in almost any area where there is an elderly population. This will be a company with trained social workers and trained registered nurses. They will work with a family. They will see your loved one. They will interview your loved one, look at your loved one, make an assessment, and then interview the family members and say, here's what we think about your loved one's physical condition. Here are facilities in the area that we think are appropriate. They will help find resources and so forth. This is something that I had never heard of before. I spoke with a lawyer that was a colleague of mine who did elder care and recommended a company in Massachusetts that we hired that helped point us in the right direction for finding my mother a facility. And also they helped us find a private nursing facility. So part of my mother's Lewy body dementia is she would hallucinate at night and try to get up and walk. And then she was a huge fall risk. So we needed to hire a private nursing company. And private nursing, $25 to $35 an hour to have a nurse sit with your loved one. Change them if they need to be changed. Help our mother get to the bathroom if she needs to get to the bathroom so she doesn't fall and crack her head. My father got sick, and then my mother got sick. Boom, boom, boom. Can't emphasize this enough. Things can work so much faster than you're planning. You want to get ahead of this. And something I didn't mention, some of the medical issues that is really important is elderly people can lose executive function. Part of my mother's Lewy body dementia, but it's very common with elderly people. Executive function is the ability to start and complete a necessary task. And
I have that now.
Well, I think every 12-year-old boy has it. Have you ever had a 12-year-old boy who will go, stay up at night, do his homework, and then go to school and not turn it in? Like, that's an example of executive function.
Yes.
But it can be very frustrating with elderly people when there's just stuff that they used to be able to do. They can't write checks. Mm-hmm. They're having a hard time paying their bills. They're having a hard time making basic decisions about groceries and so forth. You really want to get these decisions done, the family meetings done, some of these major decisions made before the executive function starts to fail. Because once it fails, no bueno, no bueno.
Other thing, getting back to the observational status, if you have a loved one who is admitted on observational status and then discharged, they are readmitted within 72 hours for something related, you can argue that observation bill should be dropped because they should have admitted your loved one in the first place. I think that it's complicated. There's a book, What to Expect When You're Expecting, When You're Pregnant, What to Expect During the First Year. There's not a book, What to Expect When Your Parents Are Getting Old. And medically, it could be all different things as our bodies age. It can be senile dementia, Alzheimer's dementia, Lewy body dementia. It can be cancer, heart failure, liver disease. As we age, we keep ourselves as healthy as we can be, but recognize that everything changes. Advocate for yourself and advocate for your loved ones.
Meetings, communication, meetings. Just fervently hope and pray that your elderly loved ones are forthcoming and open about their finances, about their health. I mean, there are things that you can control and things that you can't control. Your elderly loved ones want to clam up and be vaults with their secrets, then you've got to make the most of that and deal with that the best you can. Carol mentioned earlier, don't do it to your own kids. Don't let that experience go to waste. Learn from it. I remember my father taking my grandfather to the nursing home, and my grandfather was acting out. My grandfather had a stroke and he had dementia. And my father turned to me, I was about 8 or 9 years old in the car, and he's like, "Son, if I ever do that to you, just take a pillow and put it over my face."
My dad didn't want to leave his house. That was like the Great Depression thing. Like, you have a roof over your house. That was the best accomplishment they could have. And my dad did not want to leave. When my mom moved into a 55 and over, he would have loved it. And I kind of regret not making him do it, because what he did is he just stay up all night, sleep all day. Well, not all day, but the hours he wasn't as social. And I really feel bad, because he would have loved that.
I think that's a common thing for isolation, especially of extroverted social people whose identity was always tied in their job, like these old guys. And it's hard for them to be at home. And then they become friends with whoever's on TV.
Right. My dad started buying the coins, different things like that. And, you could hear him having the conversation with the guy on the line. And of course, they love that. "Hi, Bob. How you doing?"
Boy.
He would have loved the social aspect of that. And it's too bad that they don't see it. You know what I mean? They just don't see it. It's that house. And my parents had good health up to the very end. And what a waste that your house poor, sitting in here in good health, just to keep this house. You can't travel. You can't go places.
So they were cash poor but house rich?
Yeah.
Yeah, that was my parents. Again, poop taco. We had to let them live in the house till my father passed away. And then I began advocating to my mother, okay, now it's time to sell the house and get your own place and downsize. And that took a while. And as you mentioned, Cheryl, one of the things I did was I took my mother to a bunch of facilities in the area. I'm like, this is what's available to you. This is what you can't afford if you sell your house. And it was elderly people dining together. The meals were part of the rent. The boss picks them up and takes them places, takes them to the movies. They have movie night, bingo, they have all kinds of stuff. And they're hanging out together and watching old black and white movies together. Because goodness knows their grandkids aren't going to watch those with them, right? And she's like, wow, these are nice places. This is what I'm trying to tell you. But at that point in time, she was deteriorating rapidly. But she did eventually agree to get her into a facility much closer to Boston, off Cape Cod, near much better medical care and so forth. It was expensive, but she did have the money to pay for it for the rest of her life. Got her mother into a facility where the first floor was independent living. It was basically people in their 60s and 70s in great health. It was their apartment. And there was a bar there that had happy hour every day. And they had sports on TV, and the meals were all covered. The second floor was assisted living, which was more nursing staff to help people with certain things. And the third floor, where my mother lived the last 2 or 3 months of her life, was memory care, which is locked down. The residents all have dementia, and it's locked down so they don't wander. But it's still group meals, community activities. Lots of staff to look after them.
And that's a smart way to do it, the floors, because you don't have to walk through the people that are, worse off than you, because that's that's probably standard, but.
I would say that's nice. I would say that the dinners between the group meals and the regular assisted living, like the bar, the open bar and people socializing, and the group meals, dementia unit, it was the same food, but the conversation and the way people interacted with each other is much different. It was, nice to see them together, but they didn't enjoy each other as much on the dementia unit. And so it was just a little shocking.
It is shocking to see. It's very sad to see. Dementia sucks. I mean, that is the largest poop taco you can ever imagine, is to see a loved one with like something long-term, like 5-10 years of Alzheimer's. That's unimaginable.
Yeah.
And that wasn't our experience. I mean, I think our mother was not herself for maybe the last 6 months of her life. 3 to 6 months of really not enjoying who she was before she passed away. Yeah. Again, I'm not thankful that she passed away, but I'm thankful that the suffering didn't last as long as it does for some other family. It was a poop taco, but not as big as it could have been. As our mom, she was covered by Medicare, and the services available for her were different as she went from regular care to palliative care.
Okay, so if somebody has an illness, like a chronic illness, where they're progressing, they could qualify for palliative care. And that is at any age, really. Palliative care is just helping them be more comfortable and giving them resources for that. And that would qualify as some nursing care, some social worker, some maybe behavioral health care that goes along with that. As they progress or maybe they just don't even have palliative care to begin with, they have a terminal illness where they will probably die within a year, they'll qualify for hospice care. And some people feel that hospice care and hospice nursing, they believe incorrectly that that's going to be 24/7 care. It's not. It is great care. If you're a patient in hospice, you'll have a hospice nurse assigned to you and a social worker. They will look over and help the physician with the medication. They're not going to be there 24/7 to care for you. So families have to figure that out. Who's going to fill in the gaps?
To step back for a second, most of us when we're 65, we go on Medicare, we're going to be covered for doctor's visits and hospitalization. But there's a different menu of services available to you if you have a chronic illness and you're approaching end of life. And those services are going to be geared more towards your comfort rather than hospitalization and doctor's visits. Like the basic type of healthcare that most healthy people have, it evolves into palliative care, which is you're going to have a nurse come see you regularly that specializes in end-of-life care, and you're going to have a social worker there who's assigned to you as well. It doesn't mean you're going to die any moment. Some people can come out of that. Some people we're at stage 4 cancer and they can recover a little bit and then come out of and go back into normal. I put that in scare quotes, folks. Put that back into normal Medicare. But by and large, just for people with chronic illness, it's a recognition that the type of services you need aren't the type of services to repair your body into healthy form. It's to make whatever is the rest of your life as comfortable as it's possibly going to be.
Kind of a touchy subject, I think. Now, I've had 2 people refer to hospice as, like you're really accelerating their death. But they didn't put it like that. They put it more, like you're helping them die. And I was really taken back by that. And then I started looking back and I realized it was my sister and I that were filling in for the nurses that weren't there 24 hours. After a while, I kind of thought, this has kind of felt a little that way. And is that true? Because I didn't want to hear that after the fact.
I went through the same thing. This is the most excruciating part of it all, which is when the loved ones, the family gets together, you talk with the doctors and you make a decision that, is he or she ever going to get better? Is he or she near the end of their life? Do we continue sticking every tube up their nose, every IV in their arm, keep a heart beating as long as possible and watch the suffering? Or do you accept the fact that they've got an illness that there's no cure for? Let's make whatever the rest of their life is as comfortable as possible and be with them. That's the value you're talking about. Again, there's no instruction manual for this. Some people who are deeply religious, for example, might find that immoral. It might be their particular value set that you stick every tube up every nose and IVs and, artificial iron lungs or whatever to keep them alive for as long as possible. Mm-hmm. And that it's immoral to do anything other than that, right?
I would argue that it's immoral to keep somebody who is dying suffering. It's going to happen to all of us. I think that putting tubes and IVs and being really invasive is cruel. Prolonging suffering is cruel. You can go down that rabbit hole if you want to and blame yourself, but hospice care is basically comfort care to a person who is going to die within the next year. So as they get closer to death, they get more care, as they should. In Connecticut, where I live, there's one of the oldest hospice facilities. It's right on the water. It's beautiful. A lot of people are admitted to the Connecticut hospice facility, and they actually get pretty good care, and they're looked at. One of my friends' mothers has been kicked out of that hospice facility 3 times because she actually got better. And they look at that and say, well, she's getting better. She doesn't qualify for this anymore, so we're going to discharge her to home. That's something else to think of, too. Hospice isn't killing the person. It's alleviating the suffering for what is inevitable.
For our own mother, she was losing weight rapidly. She was not eating. She was losing all responsiveness. At that point in time, she went into hospice care and she just stopped eating. We sat as a family vigil for about 8 days as she had no food or water. They administered medication to her so she wasn't in pain, and then she slipped away, but it was very profound. We were there to see her to the other side. Emotionally excruciating. There's no words for how difficult it is to be. Watch them go over 8 days. That was horrible. Again, it's what, poop taco or poop omelet?
Right,
like, take
right.
your choice. It's bad. There's no cure. She was suffering horribly, and she made her own decision that it was time. We were there with her. She could hear us, so we just talked to her for about 8 days straight. Kind of brings me to something that's both legal and medical, which is the medical proxy. And a medical proxy is a written document that gives somebody the right to make medical decisions on someone else's behalf. In the United States, we have that legislation called HIPAA, which generally, if a doctor is dealing with a patient, it's a doctor-patient relationship, and no one else can insinuate their way into it and so forth. But there are times in which loved ones need to make decisions on behalf of their elderly loved ones. And if you have prepared a written document that you can show to the hospital or the doctor that says, I have the legal right to make decisions on behalf of my parent, that goes a long way. Because otherwise, you could get freeze up where the hospital saying, like, I don't know if you have authorization to hear about this. I don't know if you have authorization to make these decisions. Then you have to run to a lawyer's office or get a judge or whatever. Get a medical proxy up front. Like, this is your family meetings. Before things progress, get that document. Lynn, do you have anything to add to that?
Also, you should talk to them about the DNR or do not resuscitate status of what they want to do. And a lot of times people don't have a lot of medical literacy, so they don't know what that means. Old people may say, I want everything done. Okay, this is what everything done is going to mean. If your heart stops, we're going to do chest compressions on you that might break ribs, and it's a dramatic thing. We'll shock your heart and your body to try to get your heart started again. We'll put a breathing tube down your throat, start breathing for you. We'll give you medicine. We'll put central lines in, and we'll put tubes in every orifice and give you medication. And we can probably prolong your life, but we can't get you back to where you were. Many times, if you go into a cardiac arrest, we can't get you back to where you were mentally. That's not going to come back. But we can prolong life, and sometimes that's just prolonging suffering. So when you do explain, or you have the physician explain what the DNR or do not resuscitate order is in layman's terms to your loved one, they might say, I don't want all that done. Especially, I don't want that done, all these heroic efforts in front of my family. If it's my time, it's my time. That's not a bad decision, especially if they have a terminal illness or severe dementia. What are we saving? Thank you very much for having me join you guys.
We really appreciate all your input.
You're very welcome.
Love you.
Love you too.